Good afternoon, everyone, and welcome. My name is Brian Buchanan. I'm a practicing podiatrist in Grand Rapids, Michigan with the Spectrum Health Medical Group, which is a large multi-specialty organization in West Michigan. I want to thank the MPMA for inviting me to speak this year. I'm going to be talking today about optimizing postoperative outcomes, which is something everyone here cares about, and how can we do better by our patients so we can increase their chance of having a good, successful surgery. I have no disclosures. So what are we talking about? Well, we're really talking about the Hippocratic Oath. We all took that vow years ago about how we would do no harm. And sometimes you can get caught up in running a busy surgical practice or being pressed to, contribute to the office and contribute to the practice. And sometimes we push the boundaries on who we are going to take to the operating room to try to help. And sometimes we need to take a step back and say, hey, this is not the best option for the patient. In fact, that could increase their harm by operating on this individual. So trying to be sure you're always cognizant of these risks is clearly important. And how do we define postoperative outcomes? This is something that's changed over time. It used to be that the surgeon was the one that kind of defined it based on a good x-ray and a perfectly performed operation, but now most everything is patient-driven with surveys and everything else that they're contributing to their own healthcare, which I do think is important, but we have to try to come together and figure out how do we define what's a good outcome and what's not a good outcome. And of course, why does this matter? Well, it matters for the above reasons like we discussed. Obviously, everybody wants their patients to do great. We all want them to have the best outcome from an operation that we perform, makes us feel good, makes them feel good, most importantly. It's also an excellent practice builder. If you have good outcomes, that word will spread and people will refer to you. That is primary care and other physicians. Patients will word of mouth refer to you, which as we all know is incredibly powerful. So this is a vital statistic for us and for, of course, the patients that we're trying to help. And of course, how much control do we actually have over this? Well, we actually have a little bit. We don't have all the answers, but we certainly can look at the things that we can measure and come up with a good plan, put a good protocol in place to try to help these patients so that they have successful outcomes from their surgery. I kind of broke this down into 3 phases for which we can use a lever to kind of change or alter the course to try to improve the outcomes. First, of course, is things that we do before surgery. Second is things we can do during the operation itself, which I really won't get into much. And then third is what can we do post-surgery to try to increase safety and improve the patient's outcome from their surgery. So from a pre-surgical standpoint, of course, medical optimization, which is not something we're going to talk too much, just a little bit, is a very complex and large topic. Everything from diabetic control to obesity, opioid use, and psychological health. This is becoming a huge issue as we're moving hopefully soon past this pandemic with the rise in mental health. This is becoming a much bigger problem. Really trying to sort out which patients are mentally fit for an operation, and not everyone who is broken or everyone who has a deformity or has a foot problem that we try to help is a good candidate for surgery purely from a psychological health standpoint. One of my sports partners at Spectrum Health is an Andrews Fellow, and he's extremely good at sorting out some of these patients and trying to figure out who he should operate on. And his metric is if they are on 3 different psych medications, then they have to be cleared by their psychiatrist prior to an elective surgery. And he every year will have 2 or 3 patients that either don't go and get this done and don't follow up, in which case they were certainly not good candidates for surgery anyway, or those that do, and the psychologist will come back or psychiatrist will come back and say this person is not fit mentally to handle this type of operation, the stress that it will put on them. So do not overlook psychological health as something that we can actually help the patients with and try to not push them over the edge into something that could be detrimental to them. And then, of course, patient expectations, which we will get into a little bit more later. During surgery, we always want to be prepared. Do we have the right instruments? Is everything there? Is there a dirty pan or dirty fixation device that we have to reflash? Should we delay the operation for the safety of the patient? Of course, this all makes sense to improve outcomes of our patients. Of course, surgical approach. There are still times to this day after being in practice now for 17, 18 years where if it's surgery I have not performed in a while, we'll go back and look and see what's the best approach for this. Is there different approaches in the literature that seem to have better outcomes? If I'm seeing something that's going wrong in the way that I'm doing it, is there something better out there that I just haven't learned or don't know about that could easily adopt? And of course, knowing what to do if something goes wrong, which it always will. There's always issues that occur, being prepared and knowing how to fix this. if something does happen, or being aware of what you can do to try to help yourself get out of that scenario. After surgery, we think of weight-bearing considerations. How long should someone stay off the foot? Is there new technology that might improve their ability to weight bear sooner, which in some cases would improve their outcome for sure? Remember about prophylacting certain patients for DVT, following the literature on this. From a medical legal standpoint, I think it's important knowing what's safe for the patient in the operation that you're doing. Of course, communication is key. That's often the biggest thing that leads to patient dissatisfaction, and in fact lawsuits, is if they feel like they don't have a good relationship with their physician or surgeon. They don't trust them. They're not being upfront and truthful with them. So being sure you communicate well with the patient is critical for success. And then adjusting follow-up if needed. Normally we have our, as most do, kind of protocol for when patients are going to come back into the office, 2-week follow-up, 6-week follow-up, and so forth. Don't be afraid to adjust these if needed based on the situation. Infection checks, things like this, become extremely important and can be disastrous if they're just ignored or not taken seriously. Careful use of opioids, we'll get into that in a little bit. And then early treatment of complications, not ignoring what you're seeing and trying to figure out based on your experience what you can do proactively to try to prevent some of these things from becoming much bigger problems. So this effectively is what we're dealing with. As a busy surgeon or a foot and ankle specialist, surgery takes up a bit of our life, and that's something that we do on a given surgical day where you could have 4, 5, 6, 7, 8 cases, and you're doing surgery from the morning till the early evening or later afternoon, where the patient has a life and just a small section of their life is the surgery they're having. So to them, this is a huge deal, and things that we take for granted, such as anesthesia, is something that is, and for good reason, could be very fearful for them. It's easy to blow that off and not to legitimize their complaints, but it is important to take a step back and imagine if you were an accountant and you're having your foot fixed and you don't know anything about this world, how scary and intimidating it can be. So trying to refocus how we look at this may be very helpful. So what can we do as a surgeon? Well, this really comes down to difficult conversations with our patients, and these can be very challenging. Some of these topics like obesity and diabetic blood sugar control and psychological health, that's very, very challenging stuff to talk to a patient about, very personal, and does not always go well. Sometimes it ends up like this, which is less than ideal, or like this. But really what we're looking for is mutual understanding of trying to come together, and hopefully the patient understands you have their best interest in mind, and you're going to do everything you can to give them the best outcome possible by trying to minimize the risk that we can control. It ultimately comes back to empathy. What can we do? Put ourselves in their shoes and try to help them through this. So what can we do as responsible foot and ankle surgeons to improve our patients' surgical outcomes? I'm going to go over a few things here that we can all include in our practice to try to help improve the outcome of our operative candidates. The first is nicotine use. This is a massive risk factor for all kinds of things with foot and ankle surgery in particular, and this is the single most modifiable risk factor there is. We are right in the middle of ground zero for this, with the highest concentration of smokers in the Midwest, followed by the South. I hear this all the time when I talk to patients about stopping all their nicotine use, is how does that affect my foot surgery? They just don't get it. They do not understand the vasoconstrictive effects of nicotine and how that affects their ability to heal. And some of them look at you like it just doesn't make any sense, and they still can't wrap their mind around it. And some of it's probably denial, but it is extraordinarily important. Of course, this plays a big role when we're dealing with other comorbidities that all add up to poor wound or bone healing, including diabetes and arterial disease, chronic steroid use, and other things that increase the risk of problems. And when you add nicotine to this, it is confounding, makes everything much worse for the patient. And of course, it's more difficult to control post-op pain with ongoing nicotine users. And when we talk about nicotine, we are not just talking about cigarettes. We're talking about all forms. It's the nicotine itself and the vasoconstriction of this chemical that leads to the poor wound healing cascade and bone healing cascade that increases the complication rate with our patients. So all these things are part of the pre-op history and trying to figure out if they're consuming these products and how we can help them stop. I'm not going to go into the basic science of how nicotine affects the body, but as we all know, it's pretty significant. And in all forms of bone healing, it is affected, and all forms of wound healing, it's affected as well. So this is a study done couple years ago in Foot and Ankle International. It looked at the clinical outcomes of foot and ankle surgery. There had been a lot of studies performed in orthopedics that did show that smoking and nicotine use certainly does cause negative effects, negative surgical effects and poor outcomes, but the foot and ankle had not been looked at specifically up until more recently. So of course we know that this is what they found, that increased pain and lower patient overall satisfaction. Active smokers were 3 times higher to have wound complications than non-smokers, and they were between 2.5 and almost 4 times higher non-union rate. This is looking at rear foot fusions in particular, and that their osteotomies took almost 50% longer to heal. So these are all bad outcomes that we'd like to avoid. Then they looked at cigarette smoking in forefoot surgery, and we spent a lot of time thinking of nicotine in the ankle fusions, ankle fractures, rear foot fusions, triple arthrodesis, subtalar fusions, but we cannot forget about the forefoot, especially with significant deformity correction. So what they did find is the complications rate were much, much higher in smokers at 36.5%, but that interestingly, previous smokers who had quit for more than 8 weeks still had an increased risk, about double of those that never smoked. So your absolute risk from stopping all nicotine does not ever go to 0 or to the non-nicotine naive patient. So there's always some risk. However, it is certainly much less than what we're trying to strive to achieve for our surgical patients. This is an excellent concept review in Journal of Bone and Joint Surgery about 10 years ago, just really looking at the musculoskeletal effects of cigarette smoking in all facets here. And one of the things that they quoted is that 1 pack per day causes tissue hypoxia for almost 20 hours. So that means that if you're smoking a pack a day, you only have about 4 hours where your tissue is not hypoxic. And if you can imagine a healing surgery or a healing patient, this is incredibly damaging to the soft tissue and to bone. So when people quit, it tends to turn around pretty quickly. That is the good news. Immune function rebounds in 2 to 6 weeks, wound healing in 3 to 4, pulmonary function rebounds 6 to 8 weeks. So that our official recommendation at our institution is that patients have to quit about 4 to 6 weeks prior to any elective surgery. Anesthesia really like 6 weeks because the secretion rate goes down at that point. It makes it a little safer intubation if they're going to do that, and trying to manage their airway from complications, especially aspiration, is less after 6 weeks quitting. So what I kind of instructed to tell everybody here is to say, what procedures will you not do unless all nicotine is stopped? This is not something that I've done my entire career. In fact, I really didn't pay huge attention to smoking up until probably the last 5 to 6 years. And this is just something where other partners coming in, talking about this, how important it is, and really kind of wrapping your mind around, this is a big deal. This is something that we can help our patients do. Not only does it help their foot and ankle outcomes from surgery, but also improves their overall health. And I've had many patients over the years now who seemingly have completely quit. Now, I don't know for sure, as I don't follow their nicotine use far after our surgeries, but some have been extremely happy, not just that they had their foot or ankle fixed, but that they actually stopped smoking in the process. So it's really improved their quality of life and probably longevity. So typically what I will do is for any rear foot ankle, complex midfoot fusion, great toe fusion, reconstructions that are significant, hammer toe repairs that are significant, not all, but are significant, all total ankle replacements, and any revision surgery, my patients all have to stop all nicotine. It's just too risky to do in this patient population. So typically I'll tell them to stop for 3 to 4 weeks, and then we'll get a nicotine blood test. If negative, surgery can be scheduled. I do not recommend scheduling surgery at the time when you're going to get the blood test until you know that it's negative. I've had plenty of people schedule, it's not negative, and then we have to cancel, or they never get the blood test, and then we're canceling surgery close to the date, which is not ideal for anybody. So waiting until you get the negative test is incredibly important. This also significantly increases patient compliance. Those that are really wanting an operation or needing an operation, shall I say, are much more likely to stop smoking because it's hard. It's extraordinarily difficult, and we understand that, and patients struggle. So one of the things I'm not talking about here is things you can do to try to help them, and having some type of pamphlet or some type of referral program you can send them to, whether it's in your hospital or community, is obviously helpful, or just back to their primary care physician for them to try to stop this. This is incredibly addictive and very, very difficult. So when you get the blood test, this is what you'll see. You'll see the nicotine level and then the cotatine level, which is a metabolite, under 2 for both. This is a patient of mine who's having surgery soon that quit after smoking for about 10 years, and that's a completely negative study. So as someone who probably stopped maybe 8 weeks prior and then got tested. So this is someone who no longer is smoking, has any, or at least has lower risk that you can for someone who used to smoke. Next up is diabetic blood sugar control. We all know this very well, the negative effects of high glucose on wound and bone healing. This is a significant infection risk, of course. The ACFAS put out a position statement, a clinical consensus paper on perioperative management, and this was one of the metrics they looked at, understanding that it's important to try to control your diabetic surgical patients that are having elective surgery as best you can, but they did not offer a number. In fact, it's very hard to find any direct evidence on specific numbers for elective foot and ankle surgery. Some argue less than 7%. That seems to be a little bit tight for some of the things we do, though it would depend on what other comorbidities the patient has. Some papers, such as McKenzie and Gregory, had a big wide range, 7 to 10%. But at our institution, we typically will postpone elective surgery if the hemoglobin A1C is greater than 8%. And I do think this is important, especially for higher risk patients, higher risk operations. And generally, most patients can do this if they work well with their endocrinologist or primary care physician. And they need to understand why, of course. This is something I've been doing for probably the last 5 or 6 years, which is sending patients for preoperative physical therapy to really help assist them with staying on weight bearing. We all have patients, maybe they're a little older, maybe they even live by themselves, and you look at them and think, how the heck is this person going to stay non-weight bearing for 4 to 6 weeks? They look like they can hardly hold themselves up, and sometimes the answer is, well, they can't, and therefore an operation is dangerous and shouldn't be done. But sometimes they have such bad issue. This is an option that they have to deal with. Now, in the past, we would, of course, put them in the hospital and maybe a rehab facility. Nowadays, this is certainly, the pressures are there not to do that if we don't have to, and it makes most sense if we can send patients home. It's better for them. So this is a study out of Boston where they looked at, how compliant are patients when we tell them to be non-weight bearing. And so they put a pressure film in 51 casts with the explicit instructions to stay non-weight bearing, and they measured at the first post-op visit 2 weeks later and found that almost 30% were non-compliant. Non-compliance by them was defined as more than 50% of the time putting weight on this foot. So they really found that even when we tell our patients to be non-weight bearing, certainly they don't all listen, and understanding that's important. So really, do they understand what this means? I think when we say the word non-weight bearing, we have something in our head of what it means, but the patients don't hear that. They think, oh, just don't walk on it, but they can put the foot down all the time when they're standing, and eventually as the pain improves, it quickly turns into walking. But when the patients fully grasp that they could jeopardize their outcomes by putting weight on their foot, compliance increased dramatically. So telling them why we want them to stay non-weight bearing, just like why we need them to stop all nicotine and why their blood sugar needs to be better controlled, is what we really need to do so that the patients understand the reason why we're telling them this. So I usually, for patients that I deem are needed, will place a physical therapy referral for non-weight bearing training prior to surgery. It's usually just one visit. Just about every place will do this. They'll have them assess for what's the best device. Is it crutches, a walker, knee scooter, all the above? Often they'll have stairs in the therapy clinic that they can help teach them to go safely up and down if they do have this at home. And it really has been a huge improvement, not just for patient safety, but for patient well-being and feeling confident that they're going to do well following their surgery. Pain medication. This is something, of course, we all deal with, and with the opioid crisis is front and center in the news and becoming a bigger problem seemingly every day. But when you think of opioids, almost everything is talked about post-surgery, but we can't forget about the opioid requirements or what patients are taking before an operation. And there is a significant increase in difficulty, not only controlling pain, but having issues with patients that take a high level of pain medication. And unfortunately, in some of the communities, this is the case. Patients on chronic pain meds for back pain, chronic injuries, and all kinds of different things. Sometimes they're taking a significant number of MMEs per day. So Medicare changed the MMB number to 90 or greater, meaning significant opioid use. So almost all of our elective surgeries will be postponed if it's this high. You need to get the patients in with their pain management specialist or primary care physician to help get them safely down so that we can have an operation. If they can't, then the question is, should you do it or not? This is an incredibly difficult patient population to control, to keep them comfortable post-surgery. Many times these surgeries are big ones. and it can be very, very difficult. So part of the reason is expectations. This study done in JAMA looked at 4 relatively straightforward surgeries and what opioids were given to patients in 3 different countries, the United States, Canada, and Sweden. Well, what they found is that in the US and Canada, there's a 7-fold higher rate of opioid prescriptions filled in the immediate post-operative period. So basically this means that our patients expect these pain medications, and we all hear this. Question is, do we really need to give them all the time, and what numbers are we actually using? So when you look at the data from the study, they did 2 laparoscopic surgeries, a knee meniscectomy and breast excision. These are not notoriously painful surgeries, but the United States and Canada, almost 80% of all the patients were filling these prescriptions. Where in Sweden, not very many were. In Sweden, it's not uncommon to leave the hospital with no pain medication. That's just the standard. That's kind of what they do there. In the United States, I feel like you'd be sued out of existence if you did this, or patients would complain so much that you'd have to give them something. So the expectation here is that we're going to give them something. So the only thing we can do probably is either talk to them about why they don't need it for a certain procedure, or really decrease the number that we give. This was a study done in Foot and Ankle International a couple years ago that really looked at how many pain medications are our foot and ankle surgical patients actually using, and what they found out is that patients that they gave opioids to post-surgery only used about 47% of the pills given. This tells you that there are a lot of unused pills out there, and the problem with that is that these are not being disposed of appropriately. They're finding their way into the hands of their teenage kid or at a party or something else that's much worse. So being cognizant of how many you give and for what operation is key. And so what they found is that the risk factors for increased consumption was a younger age, a male, whether they used these medications before surgery. Obviously, bony or more painful surgery increased the number of opioids used. So they came up with a protocol of utilizing oxycodone for certain procedures, kind of into 3 stages or 3 classes of procedure, with class 3 being the most painful surgery, using 30, 40, or 60, and found that the patients use much less than this. So our numbers, and we don't really have a opioid post-surgery protocol. We have a loose one that we've kind of used, but I really have significantly decreased how many I give, and I think there's 2 reasons. One, patients are much more aware of the risks, and they're not asking for these numbers like they had in the past. And the second is with e-prescribing, which has been extremely helpful. If you need to refill this, it's very simple. In the past, patients had to come pick up a physical prescription. It was a little bit of a barrier, so the tendency was to give them more. But now that you can call this in electronically, they can go pick it up that day, or someone can pick it up for them. I think you can really decrease the numbers you give, with the idea that if they really do need more, you're able to get that for them. Patient expectations. So this is a big, fuzzy topic. This is not a concrete thing we can measure, but really trying to figure out, all right, what are the expectations that patient has for this given operation? Historically, this is not something that was discussed that often. You basically told the patient that, hey, you have this problem, you need surgery, this is what we're going to do, these are the risks, let's go. Patients now really need to be discussed, and this is something that always should have been done but just wasn't. What are the real expectations for the surgery? How are you going to be afterwards? What do we think will happen? And so in the past, it was determined by the surgeon, that is, success of the operation. Like I said before, surgery went well, x-rays look great, everything's fine, I don't know why you're still having pain, get out of the office. Patient-reported outcomes has been growing, as we all know, over the last 20 years or so. They look at pain levels, functional activity, satisfaction. Would you recommend the surgeon or hospital, which are all very important metrics, of course, but they're really seeing this now published, and something that we have to keep in mind at all times. So outcomes have been closely associated with the patient's perception of their post-operative recovery and satisfaction with surgery, and obviously this statement is fraught with some issues. Sometimes there's just not great outcomes. And expectation that a patient understand, yeah, he told me that there's going to be some nerve pain, and here I am 6 months after a lateral ankle stabilization, and outside of my foot still tingly and numb at times, but he told me that, so I can accept it. So things like that can make a big difference as long as they understand these are the risks, and this is the stuff that can happen with these surgeries, and if this does, these are the possibilities of treatment. So one of the things that we always want to try to do is align the patient and physician expectations. Many times we deal with mechanical issues. That's the lens that I focus on, the lens I use when I see most patients when I'm trying to figure out a treatment plan for them. Well, mechanical problems rarely occur in isolation in life. This is in a pretty good study, Ethics in Practice by Journal of Bone and Joint Surgery, talking about that there's a lot of other things going on in the patient's life that often contributes to maybe their poor outcome and not as much as to the surgery or to the mechanics that they have or the problems that they have. So as they said, quote, "It is quite possible that circumstances in the life of the patient unrelated to healthcare have more to do with satisfaction than the surgeon. Makes us feel helpless at times, but this is just the reality that our patients face." This is a study done at the Hospital for Special Surgery in New York in the orthopedic department, where they actually developed a survey that patients would take prior to surgery to see what their expectations were. This was not matched to the surgeon's expectations, but really just trying to get an idea of what did these patients expect to accomplish with the surgery or operation that was recommended. And it really helped to figure out if there were any glaring signs or obvious things that were out of alignment with what the surgeon expected. And then they could use this survey to try to figure out, yes, maybe this is someone that shouldn't have surgery, or there needs to be more education on this or this portion of the operation so that the patient feels more comfortable, understands the risks better. And this is something that they have done, and in the end of the talk and references will be the reference for this article, which I would recommend checking out. So we compared the patient's and surgeon's expectations of foot and ankle surgery. Obviously, this is different. And what they found in this study is that about 2/3 of all patients had higher expectations than the surgeons. That means that we're realists and our patients are not, to some degree. So we understand the risks better than them, but sometimes we don't do a good job communicating these risks or communicating what we really think is going to happen. Are they going to be pain-free? Almost never. That's a terrible phrase to use for somebody because you're setting yourself up for all kinds of failure. So it's very important further exploring the dialogue between patients and surgeons in order to better align the expectations. The real goal is to try to get their expectations lined up with yours. So what does this mean? Well, like everything else in life, the key to a happy life is to lower your expectations. So if we can bring their expectations back down to earth from the standpoint of what we're expecting, that we can, over deliver, under promise, or try to give them the best outcomes they can by hopefully having them understand exactly what the reality is of what we expect for them. So how do we do this? Well, we need to have honest preoperative discussion of exactly what we think they will end up with here with this operation. Never give guarantees. That's just very, very challenging. Obviously, always try your best. You're human just like your patient, and you're trying your best to help them and making sure that you optimize them as best you can before surgery. When you see something, you need to highlight it. I tell so many patients about numbness and swelling that lasts, and stiffness and color change in their foot, all these things we all hear. And I tell just about every patient, or at least I try to, and it never fails, that many of them come back and complain about it. But then I do mention, we talked about this, and many times they remember, but sometimes they just don't. So I don't know how much they actually remember when we're talking. My suspicion is it's not very much. So when patients bring a significant other or a family member with them or a friend with them during a preoperative conversation, it always makes me happy and smile, because I know that they're going to get a lot more out of that visit. So with that comes a pre-op, post-op checklist. Some of these patients don't come with anybody, and you wonder, hey, are they really capturing everything that I'm telling them? So having a checklist to have them help figure out, hey, what are we missing? What do I need? What can I do ahead of time to optimize my outcome is incredibly important. And I think it's a great idea to give every patient. And then, of course, realistic timeline on recovery. This is something that we all have to kind of discuss in ranges as opposed to absolute numbers, of course, to try to build in a little buffer just in case something goes a little slower than we expect. So we also talk about expectations, what happens when bad things happen, as they often will. Well, of course, this is a kind of one of the no-does studies that basically said that infections and revision surgery are most impactful on negative outcomes. So this really highlights the importance of a preoperative discussion of risks and complications in order to set the goals for postoperative outcomes and maximize patient satisfaction. So telling them these things can happen and that we have treatments for them can be helpful, though still, if it does, having these types of problems can really jeopardize the outcome of the surgery. So how do we improve postoperative outcomes? Well, we want to get a negative nicotine blood testing 3 to 4 weeks after they've stopped prior to scheduling surgery. trying to get the hemoglobin A1C under 8% for elective surgery or even lower based on other comorbidities and risk factors, pre-op PTOT for at-risk patients, trying to decrease some ongoing significant opioid use prior to surgery and establishing a post-op protocol, and of course trying to align your patient's expectations as best you can with your own so that everyone can walk away in a better place. Thank you very much.